Even though there is agreement around the world on how to treat hyperpressure and related organ problems, there are still problems in the real world. In part 2 of the Asia-Pacific Hypertension Summit, we will talk about hypertension control in high altitude, extreme weather, pregnancy, acute stroke, and the elderly. Among them, the disastrous effect of global climate change and the rapidly growing and aging population have changed the hypertension service scenario in a way that should cause a lot of concern. And can you show the slides about the chairperson background?
On the slide.
I'm Dr. Hao-Ming Cheng. I'm from National Yang-Ming Jiao-Tong University College of Medicine. I'm the director of Center of EBN in Taipei Veteran General Hospital. And the chairperson, my co-chair is Dr. Moncy. He's a consultant cardiologist, Department of Cardiology, and adjunct associate professor at the Institute of Health Science of University of Brunei. Welcome, Dr. Moncy. So let's get started. This is the disclaimer. Previous slide. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The view and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. And the live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook and YouTube page. Okay, so let's move on. And let's welcome the first speaker, Dr. Kunjang Sherpa from Nepal. He's an assistant professor in cardiology of National Academy of Medical Science, Bird Hospital consultant cardiologist, Bird Hospital, Nepal. And his topic is about hypertension control in high altitude, travelers versus highlanders. Let's welcome Dr. Sherpa.
Thank you, Professor Dr. Hao-Ming, for a kind introduction. Respected Program Director, Professor Junji, and Chairperson, Dr. Moncy. And thank you, APSC for giving this opportunity to present on the hypertension control in high altitude traveler versus the Highlander. In this Asia Pacific Hypertension Summit 2023, with due permission, I would like to begin my presentation. So I'm Dr. Kunjang Sherpa, working as a consultant cardiologist at Bird Hospital. So I have nothing to disclose in this presentation. My highlight of the session in this presentation will be the physiological response to hypoxia. What are the changes that occur in response to hypoxia? The physiological mechanism involved in the BP control at high altitude. What are the different physiological mechanisms involved in BP control? And what are the various clinical studies with effect of high altitude on blood pressure, especially in patients with a healthy volunteer or hypertensive patients or in patients with the highlanders? And what are the different anti-hypertensive drugs in controlling blood pressure at high altitude? There are some available evidence out there, so I will be highlighting on that. And what are the recommended statements given by the European Society and other various society on the management of blood pressure at high altitude? So coming to this altitude classification, we know that many people permanently live at high altitude because most of the people in the Southeast Asia, most of the people in the Ethiopia, most of the people live in the high altitudes, and HA exposure has become permanently common due to the mass mountain tourism and high altitude industries, and people go for their mining, so they also live for a short exposure at high altitude. During the high altitude, as we know that we go higher, the temperature becomes lower, there will be the higher solar radiation, the air humidity becomes decreased. But the most important factor is that there is a low atmospheric pressure, and which leads to consequently proportional reduction in the oxygen partial pressure in the inspired air, so it leads to the hypobaric hypoxia. So the most important factor is the hypobaric hypoxia that occurs in the altitude. And there are many physiological responses that occurs in response to the high altitude. The most important is that there occurs acute hypoxia. We know that the response to the systemic arterial vasculature is in response to acute hypoxia is vasodilation. But what happens in the pulmonary is called pulmonary vasoconstriction. Then acute hypoxia initially during the transient phase causes the transient vasodilation, which may lead to the normal or slightly decrease in the blood pressure. But within the hours, the peripheral chemoreceptors are activated so much that there is much more sympathetic activation, which leads to the increase in the heart rate and increase in the blood pressure. Similarly, in response to the environmental stress, such as the cold temperature, exercise, and it also frequently to the sympatho-excitation, which leads to the increase in the heart rate and the blood pressure. You can see when I was traveling to the Everest base camp, you can see at the height of around 5,000 meters, my oxygen saturation was 81%. So the response, the hypoxia occurs due to the hyperbaric hypoxia, and in response to this, the chemoreceptor activated and which leads to increase in the blood pressure. So in response to the time change and exposure to the high altitude, less than 2 hours, the heart rate rises, the systolic blood pressure due to the transient vitalization quite remains stable or it might slightly decrease, but within a couple of hours, even after 12 to 40 hours, there is a persistently rise in the BP blood pressure due to the sympathetic stimulation, which causes the increase in the blood pressure. The physiological mechanism involved in the blood pressure control at high altitudes are complex, and there has been many studies on it regarding the physiological mechanism. And one of the most demonstrated even in the lab and in the other parts are the persistent chemoreceptor mediated sympathoactivation. But in order to that, there are other mechanisms such as increase in the aortic stiffness, possibly mechanised by sympathetically mediated, or there may be impaired endothelial functions, or increase in the blood viscosity due to hemoconcentration. There is a decrease in the plasma volume, which leads to increase in the aortic stiffness, and it causes blood pressure. And one of the most important is that the renin-angiotensin-aldosterone system, which has been involved in the blood pressure increase at the sea level, has not been seen in the blood pressure rise above the 3,400 meters. So it was explained by the study called the High Care Himalaya Investigator. When they investigated the 47 healthy volunteers, they measured the renin-angiotensin-aldosterone system. They found that there was a suppression of the renin-angiotensin-aldosterone system when we reach the height above 3,400 meters above. And regarding the other factors, in low lander versus compared to the chronic high altitude, with the exposure of the high altitude within hours, then there will be the impairment of the vascular function immediately occurs because of the oxidative stress and the sympathoexcitation. In people living in the chronic high altitude exposure, this exposure neither intensify nor attenuates the impairment seen with the short-term exposure, but it appears to be associated with the arterial remodeling. This arterial remodeling occurs because of the erythrocytosis, increase in the plasma viscosity, and the endothelial dysfunction. So in chronic high altitude, they are associated with the arterial remodeling. So there was a studies in the Indian highlighter which shows that the high hematocrit levels seen in patients with the chronic high altitude exposure in Highlander appears to be associated with the higher BP level. So chronic excessive erythrocytosis leads to endothelial dysfunction, oxidative stress, systemic inflammation, which leads to blood pressure. Besides the raising the blood pressure, there will be some resistance in the insulin resistance, the serum glucose might rise, and the serum triglyceride also increases. So there has been various studies with the effect of high altitude on blood pressure done on the healthy volunteers, the hypertensive patient, and the patient who are on the highland. So coming to the exposure of the to progressively in patient with the healthy volunteer in the higher altitude, the High Care Himalaya studies evaluated the 47 healthy volunteers which were exposed to at the sea level. And after a short stature at the exposure to the altitude at around 3,400 meters at Namche, then immediately after reaching the Mount Everest base camp 5,400 meters, and after the 12 days stayed at altitudes. In this study, they found that there was a clear cause increase in the blood pressure either in the 24-hour daytime, either in the night time, and this further increase was increased much more in the with the more altitude climbing. But after a gradual stay for around some days, the blood pressure was stabilized during this time. And so the blood pressure continues to increase even after the daytime and also in the nighttime. And one study done on to see the effects of altitude exposure on the hypertensive patient, which was done in the studies in the patient the workers who were going to for the construction on the Kunjang Tibet Railroad in the China. They found that with more increase in the there was a greater increase in the blood pressure in patient with hypertensive compared to the healthy individuals during this year. So the patient who are hypertensive are more likely to have a greater increase in the blood pressure when they go when walk in the high altitudes than compared to the healthy individuals. Similarly, the high altitude cardiovascular research in these studies was to evaluate what will be the effect of high altitude exposure on patient with hypertensive versus the untreated hypertensive versus the treated hypertensive patient. And also they were assessing the efficacy of anti-hypertensive treatment with the telmisartan and the nifedipine group. They found that the blood pressure was increased more pronounced for ambulatory rather than for the conventional blood pressure, and the increase was greater seen during the night. So the normal nocturnal dipping, there was a marked reduction in the size of the nocturnal BP fall when they were seen at the higher altitude. And one of the most important to be understand is the BP increase tended to be more pronounced for the ambulatory, because the conventional blood pressure when we measure doesn't account for the environmental factors. The conventional BP are taken usually at the people say the people when they are at rest, and they doesn't account to the 24 hours the ambulatory blood pressure. So the ambulatory blood pressure pronounced to be more increased than conventional the conventional blood pressure when they did this study. One study which is included a little bit a higher group of patients, like 672 trackers, is 18 and older, with 60 with a prior diagnosis, 60% of the prior diagnosis of hypertension. They found that the resting in the 24-hour ABP was taken, but they were quite not in this study. They were quite not able to take the 24-hour ABP in most of the patients. And they in this study they found that although some people have the extremely elevated blood pressure in normotensive hypertension, they were found to be asymptomatic. And when they concluded that even those with a well-controlled hypertension can be reassured that their BP will remain relatively stable at high altitude. But this study has a lot of limitation because they were focusing only on the conventional blood pressure, which may have, and they were usually performed at rest. And the environmental exposure, such as the exposure to the cold, the exposure to at the nighttime blood pressure, especially in the nighttime, the blood pressure tended to rise more in the extreme altitude, and the hypoxia is much more in the extreme altitude. Were not taken into the so the environmental effects was on the BP at this altitude were not taken in this study. And with another study done at the Chile in the young military people, this was the study, only the first study that's done to whether the young climbers, young people who migrated towards the high altitude for a prolonged duration of time, like for if they exposed to a high altitude for a 12 months period, what will be the change in the blood pressure? So they found that there was an increase in the systolic blood pressure, there was an increase in the diastolic blood pressure, but they found that the hypertensive diastolic blood pressure was seen in 40% of these people in this study. So they concluded that the sustained high diastolic blood pressure should be a matter of epidemiological concern, and emphasized that there is a need for BP monitoring among young lowlanders who are exposed to the high altitude. And there are very, very few studies, and there are a lot of discriminating data between the people and the blood pressure and the hypertension adults who are permanently living in the high altitude, or those called the highlanders. The evidence, I took this meta-analysis, and this meta-analysis evaluates a lot of articles, 6 from China, 4 from Peru, 4 from India, 4 from Peru, India and China 1, Nepal 1, Pakistan 1, and the Chile 1, and various studies. Total of 71 articles. They concluded that if you see the association between the blood pressure in a high altitude in the highlander, they concluded that there is a positive association of BP and altitude, especially in the Tibetan origin. So they thought that this not only the high altitude, but there may be the additive effect of hypoxia, the lifestyle habit, particularly the diet pattern, and the genetic predisposition may have been these contributed to this association. And though the non-Tibetan high altitude population were generally found to have low risk of BP, in the both those population, the men were more likely to have likely than the women to have increased blood pressure. But there are particularly less study done in the South Asia, Central Asia, and Africa, does not have enough epidemiological data on BP and other cardiovascular risk factor in the high altitude region. So we need a more specific prevalence studies to estimate the comprehensive cardiovascular risk in this region. And another thing is that we are when we go for the high altitude, then we are doing exercise. Because of the climbing, there will be exertion, there will be some exercise. So the response to this exercise at high altitude is that patients with hypertension are more likely to prone to develop high blood pressure at exercise than the normotensive individuals. Because when they studied, they found that the hypoxia driven upward shift and steepening of the blood pressure response to exercise was seen in the higher altitude. So if your BP is not adequately controlled at the sea level, it will be even more so during the exercise at the high altitude. So, and the hypertensive people are more likely to be high BP at exercise than the normotensive individual. And these were the various studies that I haven't gone through this when making this presentation. And regarding the various drugs, there are limited studies which tested the efficacy of different drugs in controlling blood pressure during the high altitude stay, and more generally, their effects on the altitude pathophysiology. So coming to this, the study of the beta blockers, the selective and the non-beta blocker on the ambulatory papers under the hyperbaric hypoxia altitude. They were done in the 24 patients in the carvedilol in the 8 groups, nebivolol in the 9 groups, and the placebo in the 7 group. It was a double-blind parallel placebo control in the healthy lowlanders. They were randomly aligned to the placebo, nebivolol 5 mg once daily, and the carvedilol 25 mg OD. The blood pressure was measured conventional 24 at sea level after 2 weeks of double-blind treatment, and the high altitude research laboratory studied the capnarism Margarita at 4,559 meters. They found that both the carvedilol and nebivolol partly counteract the increase in the blood pressure at altitude in healthy normotensive individuals, but they were associated with the lower SpO2 level. And we know that the beta blocker also decreases the exercise performance. They decrease the blood pressure, but they are associated with the lower oxygen SpO2 level at the high altitude. And the nebivolol, the selective beta-1 blocker, is more effectively prevents the shift of the non-dipping profile. They were better in the nighttime, also 24 hours control blood pressure, and it was a better tolerated because the nebivolol has better exercise tolerance capacity than compared to the carvedilol when they did this study. And another study was done by the ambulatory, by the high altitude cardiovascular research studies when they evaluate the telmisartan, nifedipine, the GI treatment system releasing system, the combination of telmisartan and nifedipine in 47 patients in the telmisartan nifedipine group, and the placebo was 42 groups. They recorded the blood pressure at the sea level and with the high altitude, and again at the sea level later with the subsequent of 5 visits. They found that with the active treatment, with the telmisartan and nifedipine, the 24-hour systolic blood pressure both at the sea level and high altitude was decreased, and this drug was also quite tolerated at even at the high altitude. And regarding the another studies by the high-K Himalaya, where they studied the effect of angiotensin II receptor blocker during the acute and prolonged high altitude exposure, which was a randomized clinical trial. They measured the blood pressure at the conventional and ambulatory blood pressure at 8 weeks at sea level, under acute exposure to at 3400 meter at the Namche, in the 5,400 meter at the altitude of an arrival, and after 12 days at Mount Everest base camp. They were random. There was the 47 patients were randomized, 24 to the telmisartan group and 23 to the placebo group. They found that the monotherapy, the long-acting ARB telmisartan, demonstrated an impressive response on both the daytime and the nighttime blood pressure, but only the altitude up to the 3,400 meter. Whereas during the acute exposure to a higher altitude about 5,400 meter, the drug was ineffective because of the concomitant suppression of the renin-angiotensin system. In this study, they have measured the renin-angiotensin elevation system, and above the 3,400 meter, there was a suppression of the renin-angiotensin system when you go above the height of 3,400 meter. And there are few studies proposed for this, like the effect of acetazolamide on the central blood pressure, and peripheral blood pressure, and arterial stability at high pressure. This acetazolamide also has drug effect on prevention of the acute mountain sickness. So there were few patients, like the 42 subjects were randomly double-blind to acetazolamide or the placebo. What they found that the acetazolamide also counterbalance the rising blood pressure caused by the high altitude. And this has also role in the prevention of acute mountain sickness. So The impact of historodynamic on the hemodynamic alteration induced by hyperbaric XPA may be considered among the beneficial effects of this drug in subjects who are prone to mountain sickness. So to summarize the effects of anti-hypertensive drugs at high altitude, the angiotensin II receptor blockers can be safely lower the blood pressure in healthy individuals during a short exposure to around 3,400 meters. However, the ineffective during the prolonged stay at a very high altitude, 5,400 meters. Acetazolamide may lower BP, it may prevent the mountain sickness or improve oxygen saturation. However, there are limited BP data, and they can have an electrolyte, they can, with the prolonged use, they can have an electrolyte imbalance, they can have a metabolic acidosis, so this kind of things can occur. The most important part to be understand is about the other diuretics. There are no data, because since we are going up, in a high altitude, we already have a fluid depletion. There will be increase in the plasma viscosity. So it may worsen the fluid depletion caused by the high altitude state. So we have to be cautious while using the diuretics. The calcium channel antagonist nifedipine reduces the pulmonary artery pressure. These are used in the treatment of the high altitude pulmonary edema too. So, but there are some adverse effects such as the headache can occur. So they have been used in combination with the telmisartan, and it has found to be decreasing the blood pressure at the high altitude. Compared to the beta blockers, combining the carvedilol and nebivolol, the selective beta 1 both decreases the blood pressure at the high altitude, but there is a reduced exercise performance and the blood oxygenation, which is less with the selective beta 1 compound nebivolol, and the nebivolol is better tolerated than compared to the carvedilol at high altitude. We don't have the most data on the ACE inhibitor, and possibly the same as for the angiotensin receptor for RAS blocker due to RAS suppression can be contemplated from the data from the ARBs. There are some there are no such guidelines for the high altitude exposure of individuals with pre-existing cardiovascular condition, but there are some clinical recommendations given by the European Society of Cardiology, Council of Hypertension, European Society of Cardiology, the European Society of Hypertension, the International Society of Mountain Medicine, Italian Society of Hypertension, and the Italian Society of Mountain Medicine, where they recommend that patients with moderate to severe hypertension or hypertensive patients with moderate high-risk cardiovascular disease should check BP before and during the hypertension, high altitude stay at this level, which is class 2 level of evidence. And the well-controlled hypertension and patient with mild hypertensive patient may reach high altitude up to the 4,000, greater than 4,000 meters with adequate medical therapy. Uncontrolled severe hypertensive patient should avoid high altitude exposure in order to prevent the high risk of organ damage. So the clinical recommendation for the high altitude exposure on the hypertension is the therapy that the class 1 recommendation of angiotensin receptor blockers lowers BP in healthy subjects up to the height of 3,400 meters. The acetazolamide lowers the BP at high altitude while improving the saturation of oxygen and the mountain sickness symptoms. The combination of nifedipine telmisartan also effectively lowers BP in a hypertensive patient. The nebivolol, as mentioned, that the nebivolol controls the HA-induced BP increase and prevents the nocturnal BP dipping also. And when moderate to severe hypertensive patient and the hypertensive patient are moderate high cardiovascular plan exposure to a high altitude, adequate modification of their anti-hypertensive therapy should be considered in cooperation with their physician. So the take-home message is that the response of BP and its regulatory mechanism to high altitude are significantly modified by the duration of the exposure. Less is known about the long-term adaptation of the BP to altitude. Patients with hypertension are more likely to prone to develop high BP at exercise than the normotensive individual at the higher altitude. Although the initial evidence is available on the effects of BP lowering drugs, but there are very less evidence, so the individual approach should be preferred. There are some joint statements given by the European Society are available on the clinical recommendation for high altitude exposure of individuals with pre-existing cardiovascular condition. So with this, I would like to conclude my presentation. So they're saying that the well-controlled hypertension is not a contraindication to HA exposure in the magical use. We can see when I was going from to the base camp way, you can see at the Dean Buche, which is around the 4,000 feet meter, you can see a beautiful picture of the Amada Blanc, which is the most beautiful mountain in the world, one of the most beautiful mountains in the world. And with this, I would like to thank you my presentation. I would like to conclude my presentation and say thank you to everybody, especially the APSC Cloud for giving this opportunity to present in this platform. And thank you all the chairperson and the program director for giving this opportunity. Thank you, everybody.
Thank you. Thank you for Dr. Sherpa for the excellent talk. And now the time is open for discussion. Any questions, comments from the floor, from the panelists? I have a short question. We know that after exposure to the high altitude, probably we will have increased blood pressure. But how about the time that we return to the ground? That do we have any improvement in the blood pressure? Because during exercise, we will have high blood pressure for everyone. But after exercise, the blood pressure will return to a better condition because of some arterial remodeling or some kind of hemodynamic mechanism adaptation. How about the climbing mountain, high mountain? The conditions after the climbing mountain, will it become a better condition or even worse?
The highlight of this was done by the study, like whenever we do exercise at the high altitude, we have exertion at the high altitude, because when we do a climbing, the response to the high altitude is that the exercise, there will be the increase in the blood pressure in all the individuals. Those percent who have not controlled blood pressure at the baseline will likely to have more increase in the blood pressure when they are in the where they are in the high altitude, because their blood pressure response curve is in the steeper part of the line. So that means that if your blood pressure is uncontrolled at the sea level, it will be more likely to be uncontrolled at the high level, and it will be even more in those patients who are not controlled. And so the exercise response is that the blood pressure will increase much more than compared to the when we do the exertion at the higher altitude. And regarding there are the adaptation to the people, adaptation of the people, it was explained by a study done at, I explained the Chile study, where the healthy recruits, the young individuals, where the young army were stayed in the high altitude for around 12 months. They found that there was a sustained increase in the diastolic blood pressure over their time, and that used to be persists. And because when you stay for a longer time, the blood pressure in the high altitude persists for the time, it neither decreases. But when you return to the sea level, after a short-term exposure, it might decrease. But in the longer term, it might persist. But there are very few literature in the available evidence to explain that whether that blood pressure after reaching to the low level will be decreased or not.
Okay, thank you. Okay, because of time constraint, we need to move on to the next speaker. Okay, let's welcome Dr. Moncy. Dr. Moncy is my co-chair. He's the cardiologist from Nepal Hospital and adjunct associate professor at the Institute of Health Science at the University of Brunei, Jerusalem. So his topic, the second speaker is, I think, is Dr. Moncy or Dr. Kadro. Okay. Let me check. Okay, the second topic is Dr. Moncy. Okay, so his topic is about hypertension control in extreme weather, too hot, too cold matters. Okay, let's welcome Dr. Moncy. Dr. Moncy, can you share your slide?
Share the slide.
Yes, we can see your slide.
Thank you, Dr. Hem. So I am Dr. Moncy from Brunei. Selamat petang. Good afternoon to everybody. So thank you. Let me thank first Dr. Jin Lee for the program director for inviting me to this webinar in the APSC in connection with this Asia Pacific Hypertension Summit of 2023 of the second section. My topic, which was given to me, is the hypertension control in extreme weather, too hot or too cold, whether it matters. So I want to just highlight on this hypertension in the seasonal variations of hypertension in extreme cold or extreme hot. You can just see that Earth is a planet of extremes. We can see extreme hot in few countries, extreme cold in so many countries, and how this affects hypertension, how this affects blood pressure. See the two situations, we can see the people working at a too hot atmosphere, people working at too cold atmosphere. And Brunei is a small country which is located in the north coast of Brunei, where the climate of the Brunei is equatorial, which is not too hot, but humid and rainy throughout the year. Temperature is quite stable, although they are slightly higher from April to August, when they can sometimes reach up to 36 degrees centigrade. At night, it never gets cold. And the last few decades, the temperature has never dropped below 20 degrees centigrade. Just traveling to the Brunei. Just coming to the hypertension, as you know, hypertension is the most important non-modified risk factor of the cardiovascular disease, second only to smoking as the preventable cause of death. It has been long known that the level of blood pressure has been associated with the risk of cardiovascular complications and death. The prevalence of hypertension in Brunei is high, both in men and women. A Brunei epidemiological cross-sectional stroke study has looked upon the pattern of hypertension and stroke risk. To estimate the prevalence of hypertension aged above 18 years has shown about a 43.3% of hypertension adults. The Brunei National Hypertension Guidelines published in 2019 keep a traditional definition of above 140/90 for the diagnosis of hypertension, but adopts the AHA treatment threshold of more than 130/80 for those who are an elevated cardiovascular risk and those on treatment with the target blood pressure control. Epidemiological studies have consistently demonstrated an increased risk of cardiovascular during cold temperatures. Hemodynamic changes associated with cold temperature, increased thrombogenicity may account for increase in the cardiovascular risk and mortality. Studies using both in office and out-hospital blood measurements has consistently shown an elevation of blood pressure during cold seasons. The large difference in blood pressure between cold and warm months may increase the incidence of hypertension and reduce the hypertension control, potentially result in increased cardiovascular risk, especially those at the risk of cardiovascular disease. The current trend in the global warming and the climate change may have a profound impact in the epidemiology of hypertension and cardiovascular disease, as changes in the may significantly affect both blood pressure variability and cardiovascular disease, especially those with the cardiovascular risk and the elderly people. Furthermore, a climate change could have a significant influence on hypertension in Asia, considering the unique characteristics of the hypertensive patients in Asia. Asians tend to be salt sensitive, have a higher morning surge in blood pressure with morning hypertension, and a higher incidence of nocturnal hypertension. An increase in the ambient temperature decreases in the mean daytime average and morning surge in blood pressure, but increase in the nocturnal blood pressure is difficult to predict how the environmental changes may affect the epidemiology and prognosis of hypertension in the Asia-Pacific region. A study conducted at the University College of London in the United Kingdom adds a new risk factor for hypertension is the temperature of your home, which has been documented in the association between, in the Journal of Hypertension, association between indoor temperature and the blood pressure. The colder living conditions are linked to an increased risk of hypertension. A review of the consensus statement from the European Society of the Hypertension Working Group on blood pressure monitoring and cardiovascular variability analyzed the evidence of the seasonal variation and concluded that blood pressure is usually several millimeters lower during the summit and higher during the cold season. Office measurements of the systolic blood pressure by diastolic pressure is about 5.3 to 3 millimeter on average, lower in summer compared to winter. A study conducted for the Association of Blood Pressure with the outdoor temperature 8,000 patients, elderly patients, the front CT showed systolic blood pressure decreased with increasing temperature with an 8 millimeter decrease, the lowest of more than 7.9 and the highest at 21. In another study performed in individuals aged 65 to 74 years, was based on only 90 subjects recruited. General practice found 1 degree centigrade decrease in living room temperature was associated with a rise of 1.3 millimeter in systolic blood pressure and 0.6 millimeter diastolic blood pressure. For individuals with the coolest homes, the average systolic blood pressure was 126 by 70 and the diastolic was about 74 millimeters mercury. And those in the warmest homes was 121.12 and 70.1 respectively. A 2009 study in JAMA Internal Medicine found that the systolic blood pressure decreased with increasing temperature with an 8 millimeter decrease separating the lowest and the highest temperature. The study, which included the subjects 65 years and older, found that the change in blood pressure was greatest in those with 80 years and older. The researchers found that the careful monitoring of blood pressure and antihypertensive would reduce the risk the periods of extreme cold. So you should have a hypertension constant check on blood pressure during the winter season. What constitutes the extreme cold and its effects across the various areas of the country? The cold is a pretty subjective additive. Exposure to cold induces endothelial dysfunction and increased blood pressure, which may be the main contributing factors of increased risk of cardiovascular mortality. Seasonal variation in ambient temperature influences both the mean and the blood pressure circadian rhythm, which may have a significant influence on the seasonal variation in cardiovascular risk. So what are the causes of the winter hypertension? A significant increase in the systolic and diastolic blood pressure during winter compared to summer was clearly documented. There are several possible reasons for the seasonality of hypertension: external temperature, physical activity, seasonal variation in noradrenaline, catecholamine, vasopressin, important factors which play in the blood pressure variability. However, the evidence suggests that a number of simple precautions to reduce risk of hypertension in winter could be taken. This include adequate indoor heating, wearing protective clothing, especially in elderly patients. Attempts should be made to ensure that our lifestyle in relation to diet, regular exercise, are at least in healthy environment in summer. Higher rates of hypertension as well as the potential increase in deaths from stroke and heart disease in winter months suggest indoor temperature should be taken as seriously in the diagnosis and treatment decisions of hypertension, which provides a strong enough evidence to be used to advise certain patients with hypertension. There are several physiological explanations for the effect of temperature on blood pressure. Cold exposure activates sympathetic nervous system, which increases the activity of the renin-angiotensin system, suppresses the endothelial nitric oxide synthetic expression, decreases the nitric oxide production, which contributes to cold-induced hypertension. The renin-angiotensin system mediates the cold-induced increase in endothelial 1 production, which is also a potent regulator of the vascular tone and blood pressure. Cold exposure upregulates the endothelial A, but downregulates the endothelial receptors and mediates a thermoregulatory vasoconstriction. So what are the recommendations for the The recommendations for the hypertensive patients from European Society of Cardiac Concerns group is that if the symptoms consisted of overtreatment appear with the temperature rise or rise in observed cold weather, some modification treatment regime may be warranted. They recommend that blood pressure change should be confined or without office techniques, preferably in ambulatory 24-hour BP monitoring or a home monitoring. Importantly, other causes of the change should also be investigated and excluded. If symptomatic hypotension is divided, down titration of the treatment should be considered. Indoor temperature has to be taken into consideration as it could affect a diagnosis. If someone has borderline hypertension, the people with the cooler homes may need higher dose of medications. So what are the 5 tips to reduce high blood pressure in winter? One is you minimize the outdoor activity to reduce the sudden changes in the heart workload, avoid extreme exertion, dressing layers to conserve body heat, always wearing a scarf and gloves when stepping outside to minimize the amount the skin exposed to outdoor temperature, which may increase the blood pressure. Avoiding alcohol and caffeine as they may cause the body to lose heat more rapidly. Eating a well-balanced diet consisting of a variety of foods rich in nutrients that have lower the blood pressure, reducing salt intake. The DASH diet, which is recommended for people living in this condition, basically the DASH diet emphasizes on vegetables, fruits, low-fat dairy foods, moderate amount of whole grains, fish, poultry, nuts, and as per the Mayo Clinic recommendations. The recommendation for hypertensive patients in the European Society of Hypertension Concerns Group is that the symptom consists of overtreatment appears the temperature rise or rise is observed during cold weather. Some modification of treatment regime is warranted. Now coming to the extremes of heat, this is not, there is no universal definition for extreme heat, but generally accepted extreme heat consists of minimum 2 to 3 days of unusually hot weather and often places additional stress for local infrastructure. You can see that the temperature extremes of temperature in the various countries ranging from about 55 to 45 degrees centigrade. So you can see the extremes of weather. And the office measurements of the systolic blood pressure and the diastolic blood pressure is 5.3 to 3.3 lower on an average in summer compared to the winter. So although the summer, the heat does not pose significant risk for those with high blood pressure, it is important to practice caution if you are in the daytime, especially if you are over 65. Those 65 and older are more likely to experience heat-related problems. Older adults are more likely to have chronic conditions, to take medications can affect body temperature. Older adults are generally less likely to adjust to sudden temperature spikes and dips. Hot temperature causes increased blood flow in the skin and dehydration. Lower blood pressure significantly dizziness, fainting, falls, which are more dangerous in older adults. So what can we do? It is particularly important to practice sun safety if you are 65 or older. In addition, limiting your time in the sun, you should always wear sunscreen, sunglasses, or hat in outdoors. Stay hydrated, wear loose-fitting denture fabrics, avoid peak heat and skip a stove. Cooking with an oven and a stove can cause your house to overheat. Hotter days, stick to microwavable foods or fresh, low ingredients. So American Heart Association suggests that everyone follows the top 4 hot protective measures. One is the watch clock. It's best to avoid outdoors in the early afternoon because the sun is usually at its strongest, putting you at highest risk of heat-related ingredients. Dress for the heat, wear light-colored clothing and breaths and fabrics. Drink up, stay hydrated by drinking few cups of water before and during after going out to exercise. Take regular breaks when. So hypertension control, Sungha Park and University in Korea and colleagues from the Hope Asia Network recently reviewed the influence of ambient temperature on hypertension in Asia and cautioned against down titration or reduction in the number of medications in summer since the nocturnal blood pressure was not reduced. In clinical practice, antihypertensive agents tend to be reduced in summer to avoid excessive decrease in blood pressure. Antihypertensive medicines like ACL or angiotensin receptor inhibitors, beta blockers, cancer channel block diuretics, which affect blood pressure response or deplete the body of sodium, can exaggerate the body response to heat and cause to feel ill in extreme heat. Diuretics are commonly reduced in elderly hypertensive patients and particularly chronic kidney disease who are deemed to be at high risk of dehydration, acute kidney injury in summer. Those with diabetes who are deemed to high risk of orthostatic hypotension. Plasma, sodium, and urea are reliable markers of this condition useful in deciding down titration. For specific patients, it's recommended to measure not only home blood pressure, but also daily weight to monitor the fluid status to detect any dehydration. Some blood pressure medications can increase your sensitivity, which could raise the chance of sunburn photosensitivity, reactions are characterized by possibly blisters, which is individual risk. Remember that everyone is different in their response to temperature. It is important to regularly monitor blood pressure if any sudden change, including those with temperature related. So the recommendations in the hot weather of the hypertensive patient, the European Society of Hypertension Concerns is that if the symptom consists of the overtreatment appear with the temperature rise or rise is observed during cold weather, some modification of treatment regime may be warranted. Extreme weather events suggest to exercise vigilant care for patients with hypertension, particularly those who are elderly and those with relevant comorbidities such as kidney disease. It is recommended to measure not only home blood pressure, but also the daily weight to monitor the fluid status to detect early dehydration. So from this talk, so the hypertension control in extreme weather and too hot and too cold really matters. Thanks. Thank you.
Okay, thank you for Dr. Moncy for the excellent talk. So the time is open for discussion. Any questions from the panelists? I have a question that's in my mind for a long time, that we, from epidemiology study, we observe in summer, in hot weather, the nocturnal blood pressure is increased, as demonstrated in your presentation. And Dr. Sangha Park also stressed that we should be carefully down titrate the medication because the nocturnal hypertension is there. So can you explain more about this phenomenon? Why the summer, the hot weather can increase the nocturnal blood pressure?
See, in the nocturnal blood pressure remains high because really it is a temperature fluctuation, because the daytime we have the temperature hike. So in the night, usually the temperature comes down. So there may be a rebound hypertension which have occurred during the daytime. So
Okay.
that may be the only explanation which I can explain now. It's a rebound hypertension which we see in the daytime hypotension.
Probably because of the fluid status, right? Fluid homeostasis.
Yeah, of course. Yeah.
Yeah. Okay, that's a good mechanism explanation. Okay. Any questions from other panelists? We still have probably 3 minutes. Any questions? So do you think we should adjust the BP target labels at in different seasons, or just maintain the similar the target label of blood pressure control?
Pardon me, it's not clear. Can you?
In different seasons, should we use different strategies to manage our blood pressure, different targets or different medication?
So the recommendation, what they are saying is, you need not change unless the patient showing symptoms.
Okay.
So you need not change the medications unless the patient is symptomatic.
Okay. 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 If there are no further questions, I will conclude these sections and hand my chair positions to Dr. Moncy. So Dr. Moncy, please introduce the next speaker.
Thank you.
Thank you.
So let me welcome Dr. Waleed Kadro from UAE.
Yes, I'm here. Yes,
Yeah.
I'm here. Can you hear me?
Yeah, yes, I can hear you.
Okay.
And
Okay.
let me first welcome Dr. Waleed Kadro, who is the Chief of Cardiology and Director of the Cath Lab and Interventional Cardiology, the Senior Consultant Interventional Cardiologist of Sulekha Hospital, Sharjah, UAE. Welcome, Doctor. And you will be talking on hypertension control in pregnancy.
Yeah.
Timing and the choice of pharmacological therapy. Welcome, Doctor. Yeah.
Okay. Thank you very much for the nice introduction. Let me first also thank the organizing committee, Dr. Lin, and the Asia Pacific Hypertension Summit. And I have to really thank the Emirate Cardiac Society who selected me to be their representative in this symposium. I'm a cardiologist originally from Damascus, Syria, but I've been practicing in the UAE for more than 5 years. So let me share my screen. Okay. Can you see my screen now?
I'm not seeing. So what about other people? Yeah, now it's okay, Doctor. Yeah.
Okay. Okay. So I'll be covering the topic of hypertension in pregnancy and the timing of starting treatment and which pharmacological agent to use. So we'll start with some introduction about hypertension in pregnancy, and I'll use the term HDP, that's hypertensive disorder of pregnancy. Let me advance. It's not advancing or what? Okay, I'm sorry, I have to reshare again. Okay. Okay, I'll put it on full screen. Okay. So the hypertensive disorder in pregnancy are a major cause of maternal and fetal morbidity and mortality, and it accounts for about 10% of pregnancies worldwide. This may increase due to the increasing age of pregnant women and the obesity, increasing obesity in the conceiving women. So it is important to distinguish about the types of hypertension in pregnancy, and we'll go into those definition a little bit later. There is a consensus that we need to treat severe hypertension when the systolic high blood pressure is more than 170 and diastolic blood pressure more than 110, and consider that as an emergency and the patient need to be hospitalized. So the current European guidelines recommend starting treatment for persistent hypertension when the blood pressure is more than 150 systolic and more than 95 diastolic. That's totally different from the recommendation from the European Society of Hypertension and the American College of Cardiology for treating non-pregnant women. We know that we have to get the blood pressure more tighter, less than 140, and in some studies less than 130. But for the pregnant woman is a little bit different. And when there is other comorbidities, especially in the presence of gestational hypertension with or without proteinuria, or pre-existing hypertension that was with superimposed gestational hypertension, we need to start treatment when the systolic blood pressure is more than 140 and the diastolic more than 190. There are a lot of medication, but the data on labetalol, methyl dopa, and calcium antagonists are the most available data. And the selection of antihypertensive depend on the type of administration and the expected time of delivery. So there are two major studies. One published in 2015, the SHIP study, and the CHAP study, which was published last year in 2022, recommended that there is that we should lower the threshold of initiating hypertensive therapy in the woman, in the pregnant woman. Just to remember that the woman with hypertensive disorder of pregnancy, especially preeclampsia, they have a high risk of developing another cardiovascular or major cardiovascular event later in their life. So we need to document the obstetric history, and that should be part of the cardiovascular assessment in every woman. The pregnant woman with hypertensive disorder of pregnancy also is at increased risk of abruption, stroke, pulmonary edema, thromboembolic events, and DIC. The fatal risks include growth retardation, intrauterine death, and the neonatal risk includes increased preterm birth, low birth weight, and prolonged neonatal care. So there are some physiological changes in the blood pressure during pregnancy. So early in the first trimester of pregnancy, there is significant drop in the blood pressure due to vasodilation and production of prostacyclin and nitric oxide. and this may cause the blood pressure to drop by 8 to 15 millimeter in the diastolic blood pressure, and followed by gradual increase after the week of 24 of pregnancy. This blood pressure fluctuation is seen both in normotensive and hypertensive women. So some of the patient with who has a history of hypertension may be found to have normal blood pressure, and once their blood pressure rise after the second trimester, they may consider to have gestational hypertension, although this is misdiagnosed as gestational hypertension because she has chronic hypertension. The blood pressure usually falls immediately after delivery and does start to increase again 3 to 4 days postnatally and continue to rise. And remember, 10% of maternal deaths is due to hypertensive disorder in pregnancy, and the mortality occur about 10% in the postpartum period. So those are the hemodynamic changes in pregnancy. That's for the blood pressure. Just remember, the pregnancy is like a small exercise stress test. There is increase in heart rate, increase in stroke volume, and increase in cardiac output. So what are the classification for the hypertension in the pregnancy? There is gestational hypertension. That means the blood pressure rising after the week of 20 weeks of pregnancy and continue to rise during the pregnancy and start to fall down after 6 weeks of the postpartum period. The preeclampsia, when it's associated with other organ damage, chronic hypertension when the blood pressure is present before pregnancy and is mainly at the beginning of the pregnancy or before the 20th week of pregnancy. There is the chronic hypertension with superimposed preeclampsia and chronic hypertension with superimposed gestational hypertension. So what's the number? The definition is when the blood pressure is more the 140 systolic and 90 diastolic. That's gestational hypertension when it occurs after the 24th week of pregnancy. When it's associated with proteinuria or not necessarily proteinuria, one of those following findings: low platelets, microalbuminuria, increase in creatinine, increase in liver enzyme, pulmonary edema, headache, visual symptoms, all of that are eclampsia. When it's associated with convulsions, all of that are preeclampsia. When it's associated with convulsion, it's called now eclampsia. And just remember, chronic hypertension is in the back of all of those things. And preeclampsia is known as, it's not just hypertension, it's multi-system disease with progressive disorder. So points to remember that pre-existing hypertension is associated with 25% increase in the risk of developing preeclampsia. So every patient with pre-existing hypertension is a high risk of developing preeclampsia. And there are some cases of what we call transient gestational hypertension, where the blood pressure rises a little bit and then come back to normal within few minutes or within few hours. And just remember, this is not a benign condition. It's associated with 40% increase in gestational hypertension or preeclampsia. So this is not a benign condition. So every patient with some transient elevation in the blood pressure should be followed closely and monitor for their blood pressure in order to document the diagnosis and put the plan for the follow-up. So what are the prediction of developing preeclampsia? There is what we call the high-risk patient. The high-risk patient are the patient with previous pregnancy associated with preeclampsia, and fatal gestation. The patient was a twin or triplet are at high risk of developing preeclampsia. Chronic hypertension, as I mentioned, is a high risk for developing eclampsia. Type 1 or type 2 diabetes, renal disease, and autoimmune disease, whether SLE or antiphospholipid syndrome. So there are some moderate risk cases. The moderate risk cases is the primiparity or nulliparity. The patient with no history of previous pregnancy, obesity, and increased BMI more than 30, family history of preeclampsia. If the patient mother or sister had a history of preeclampsia, she is considered as a moderate risk. Extreme age, when the age of the age of the pregnant woman is more than 35 years, and even at the lower age, less than 18, it is considered moderate risk. And some socio-demographic characteristics like African American women and low socioeconomic levels. There are some other personal risk factors. If the pregnant lady has herself history of low birth weight when she was born, or a small gestational age, or previous pregnancy, poor pregnancy outcome. And another factor is the increased time interval between the pregnancies due to use of prolonged contraception or use of condoms by the sexual mate. So what's the management? It's the management of hypertension and hypertension in pregnancy is like a balancing act between the maternal benefit and the fetal health. So best care for the mother result in fetal growth retardation, and the best care for the fetus may put the mother at risk. So what's the management? The management is to control of hypertension by using hypertensive medication, prevention of eclampsia, and early delivery. So we'll try to cover the important points of control of hypertension. So and the management, just remember that the patient with mild pre-existing hypertension, where the blood pressure systolic is between 140 to 160, they are at low risk of vascular complication, cardiovascular complication in the short time frame of pregnancy. And if the patient has essential hypertension but normal renal function, they are at low risk of developing maternal or neonatal bad outcome. Some women treated with pre-existing hypertension and mild hypertension, we can withdraw the medication during the first trimester or the first half of pregnancy because of the physiological drop in the blood pressure that we mentioned before. However, close monitoring is necessary for resumption of treatment. So what are the target? The target is not like the target that's mentioned for the Society of Hypertension or the European Society of Cardiology or the American College of Cardiology. We are not going to hit the target here. We are going to go a little bit different. Because drop in the blood pressure may affect the blood supply to the fetus and give a poor outcome. So we have to consider this other symptoms and consider the syndromic approach. So if the patient has a high blood pressure in association with any of those things like thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, or new onset cerebral disturbances, whether it's headache or visual disturbances, thus we need to start the treatment, whatever the number is there. And the principles is when to treat and what's level of hypertension to reach and how to treat and what to use for medication and what to avoid. The level, as we said, when it's severe, that's more than 160 systolic, 110 diastolic, that's severe, need to be treated. Moderate, 150 to 159 systolic and 100 to 109 diastolic. Mild is 140 to 150 systolic and 90 to 100 diastolic. So if we concentrate on the diastolic, that's so for severe hypertension, always recommended to treat because it is believed to reduce the risk of maternal stroke. For mild to moderate hypertension, it's prudent approach because we need to consider the other comorbidities and the symptoms of the patient, like headache or visual disturbances, and thus will start treatment. Because the benefit and potential risk of treatment is less clear. So the concern that aggressive lowering or medication of blood pressure or medication themselves may inhibit fetal growth and expose to harmful effect or side effect of the drug. So when to start? As we said, when the diastolic, to start for the diastolic blood pressure at a 90 or 100, we know that maternal treatment did not increase the risk of fetal growth retardation and did not cause excess fetal risk when we decrease the blood pressure diastolic to 85. And this is in the CHIP study that I did mention and was published in 2015 in the New England Journal of Medicine. So dropping the blood pressure to the diastolic to 85 did not increase the risk of fetal growth retardation and did not do any harm to the fetal risk and give less progression to severe hypertension. So when to start? As we said, immediately when the systolic blood pressure is high and associated with symptoms. We can watch the patient for 2 hours when the systolic blood pressure is high, more than 170, but without symptoms. We can watch the patient for 24 to 48 hours for observation and start the treatment when there is systolic blood pressure more than 140 and diastolic more than 90 at any time, but after observation for 24 hours. If there is gestational hypertension, whether it's associated with proteinuria or not, need to be started after 48 hours. Pre-existing hypertension with the superimposed gestational hypertension and hypertension with HMOD, that's called hypertension mediated organ dysfunction, whether there is epigastric pain due to liver congestion, visual disturbances, or headache. And whenever the systolic blood pressure is more than 140 or diastolic more than 95, in all other circumstances after watching the patient for 24 to 48 hours. The benefit that we know that reducing blood pressure reduces the occurrence of severe maternal hypertension during pregnancy and did not, in one study that the SHIP study did not affect the preeclampsia or the maternal stroke. This is in one study, but there is a new study that was published last year about that's called the CHAP study, that's treatment of mild and chronic hypertension during pregnancy, and that showed significant reduction in the maternal outcome. That's the occurrence of preeclampsia without any effect on the fetal outcome, without any increasing the damage to the fetus or fetal growth retardation. So that's the primary outcome of preeclampsia and severe feature. There were significant reduction with significant p-value. So the safety, what are the safety of a hypertensive medication? Just remember, all hypertensive medication cross the placenta, but there is no data or randomized study on any of the drugs. But the best drug which was studied longitudinally is methyl-dopa, but we hardly use this medication. So how, what are the points to remember in treating hypertension in pregnancy? To avoid ACE inhibitor, ARBs, and direct renin inhibitors, all of that associated with renal anomalies and damage to the fetus. So that's avoided. Also, minor corticoids with spironolactone or epinephrine that may affect the fetus and cross the placenta and is not studied in the pregnancy. So that's to avoid. Thiazide diuretics, it may reduce the intravascular volume, so it should not be used unless there is pulmonary edema. and it can be used after the delivery postnatally if hypertension persists to prevent eclampsia or congestion. The nitroprusside, we need to avoid that because of the risk of the cyanide poisoning. So it should be used only as an emergency and for short period. That's the nitroprusside. So we did mention all of that. So what to use? The emergency hypertensive treatment for hypertension is labetalol is the first drug and can be given IV stat and repeated every 30 minutes, or can be given infusion with fewer side effects. There is some contraindication, like the contraindication for beta blocker, asthma, or heart disease. Hydralazine can be used IV or IM or infusion. It has side effect, headache, fetal distress, and some hypotension, and may cause also some fluid retention. Nifedipine can be used, especially the oral or the long-acting one, and can be given, and it can act quickly within 30 minutes and can be repeated. Just the most important point is to try to avoid short-acting sublingual nifedipine. It did increase the incidence of MI, and this is considered malpractice to use sublingual nifedipine. To maintain the antihypertensive treatment, labetalol can be used orally with a dose of 200 to up to 2,400 milligram a day. Nifedipine can be used with a maintenance dose of 30 to 120, and methyl dopa can be used with a dose of 500 to 2,000. Labetalol has both alpha and beta adrenergic blocking activity and may preserve the uteroplacental blood flow. And in some study, it may reduce the incidence of proteinuria. It has more rapid of action compared to methyl dopa. Labetalol may have some hepatotoxicity and some adverse outcome, especially in chronic hypertension. There are some limited data on the other beta blocker like bendolol and long-acting metoprolol. So hydralazine, as mentioned, can be used orally, and hypotension is really difficult and less predictable. It may happen, and it may cause fluid retention and reflex tachycardia. For nifedipine, it is safe, immediate release, and sustained release for the maintenance. As I mentioned, avoid using sublingual short-acting. The data for other calcium channel blocker like amlodipine, felodipine, verapamil, and diltiazem are lacking data. Methyl dopa, it is widely used, it's safe. We have data for long-term safety for this medication was followed for more than 7 years, but it has only mild antihypertensive effect and has slow onset of action. It may take up to 24 hours to work and will not achieve target blood pressure. However, it is well tolerated. Clonidine, it has some side effect and may cause rebound hypertension. So we'll try to avoid it, but postnatally may be used. Nitroglycerin is an option for treating pulmonary edema and can be given in infusion. The other treatment are bed rest. There is no data about bed rest may prevent the exacerbation of hypertension, but it may improve the uteroplacental blood flow. But the data are really rare. So patient with stable chronic hypertension is not recommended to get bed rest in order to avoid the risk of thromboembolism. The salt restriction, also there is no data for salt restriction, and salt restriction may deplete the intravascular volume. So we'll try to keep the patient on their regular salt diet. Magnesium sulfate, it's not as an antihypertensive, but it may improve the response of antihypertensive and prevent the progression of preeclampsia. So our target, as we said, is not the target in the middle, is try to do that a little bit for systolic blood pressure 130 to 140, and diastolic between 80 to 100. And how rapid can we do that? It's controversial, but just remember, a quick drop in the blood pressure may cause cerebral ischemia or infarction. So we'll try to reduce the blood pressure to 25% of the number over 2 hours. So what other intervention can we use? It's mainly to educate the patient about the symptoms of preeclampsia and teach them about those symptoms, so they will notify their doctors as soon as those clinical manifestations show up. Follow up in high-risk women, for the high-risk woman, for frequent visits to check her blood pressure and check the other blood tests. What other intervention? Losing weight, especially in the obese patient, and not to exceed the recommendation for gestational weight, and try to reduce the chance of multiple gestation, especially if the patient getting IVF. If the IVF getting her multiple fetus, that's increased the risk of developing preeclampsia or blood pressure. Low dose aspirin is really beneficial to prevent the incidence of preeclampsia. Calcium and antioxidant are considered to reduce the risk of preeclampsia. So let's talk about, a little bit about aspirin. Aspirin, there is meta-analysis of big study, more than 40,000 women. It showed reduction in proteinuria and preeclampsia. It showed the reduction in fetal and neonatal deaths, and reduction in preterm birth, and reduction in small for gestational age. So all the composite series adverse maternal and neonatal event outcomes has been improved. So, but however, if we continue giving the aspirin, it may increase the risk of postpartum hemorrhage, but it doesn't affect the incidence of abruption, and there is no evidence of affecting the incidence of HELLP syndrome. So we'll give aspirin, as we said, to the moderate or high risk of developing eclampsia, and I did mention those moderate and high risk at the beginning, and the high risk multiparas, especially in the IVF patient, and the high risk per algorithm, whether due to proteinuria or increased blood test like elevation of S-FLET. The aspirin after preeclampsia doesn't give any benefit. So if we need to give aspirin, we need to give early at a dose of 81 to 150 milligrams. Start that before the 20 weeks of pregnancy, especially prefer to be started at 12 weeks of gestation, and continue and stop that at the 30 week of gestation, or at least 7 to 10 days of before the delivery. Calcium, it is documented that it may reduce the incidence of preeclampsia, so it is recommended to give some calcium, but the dose is not well studied. Low molecular weight heparin has no benefit. Remember, statin are contraindicated during pregnancy. Vitamin C and vitamin E supplement is not recommended. The other things, vitamin D may reduce the risk of preeclampsia. Folic acid has no effect, and fish oil has no effect. So nitric oxide donor also has no effect, although they give vasodilation, but has no effect to prevent preeclampsia. Just hypertensive drug, it may reduce the progression of hypertension. And as I showed you in the study, it did improve the maternal outcome. The diet, there is no beneficial result of any diet, whether to increase the protein or reduce the protein, increase the magnesium, or do salt restriction. Behavior changes are a little bit important. There is no strong evidence, but to do regular exercise may prevent the progression of gestational hypertension, may may prevent the development of gestational diabetes and prevent the other side effect. So there is some points to remember about prognosis after pregnancy, that the woman with gestational hypertension has a risk of developing hypertension and stroke later in their life. So and also preeclampsia are associated with four-fold increase of developing hypertension and developing ischemic heart disease, stroke, and cardiovascular death. So every patient with hypertensive disease of pregnancy she's at risk of developing hypertension probably 10 years later. And the ECHO study showed that they continue to show some diastolic dysfunction compared to the other patients who developed hypertension but did not have any history of hypertensive disorder of pregnancy. So we need to follow those patients and get all their obstetric history. And once we get those obstetric history, we can follow them regularly. And just remember also, hypertensive disorder of pregnancy may affect also the cognitive function of the mother, and they may develop vascular dementia later in their life. And also there is some study showing that they may affect the cognition of their fetus. So follow-up after pregnancy, we need to do close follow-up even after the patient discharge, give her blood pressure monitoring device so they can report high blood pressure in the postpartum era. If they develop high blood pressure, they may progress either to what we call late onset postpartum, late onset preeclampsia, or they may develop postpartum cardiomyopathy. So all the cardiologists and the general practitioners should include the obstetric history of those patients and get that. With that, we'll stop here. I don't think we need to do any other points. I think we covered most of the points. There are some points that's for the obstetrician, how to deliver, but I don't think it's the appropriate place here to discuss. We are a hypertension society.
Thank you, Dr. Waleed, for his excellent and elaborate talk on hypertension in pregnancy. Thank you so much. So next is, because of the shortage of time, so I don't really need to have any question answer section. So we'll go to the next speaker. Yeah, he is Dr. Hao-Ming from Taiwan. He is the professor of the program of the Interdisciplinary Medicine, National Yang Ming Chao Cheng University College of Medicine. He was also the director of the Center for Evidence-Based Medicine, Taipei Veterans General Hospital. Welcome, Dr. Hao-Ming from Taiwan. He will be talking on hypertension management in acute stroke. What's the difference between ischemic and hemorrhagic mechanism for hypertension management? Welcome, Dr. Hao-Ming.
Thank you for Dr. Moncy for the introduction. So let me share my slide. Can you see my slide?
Yes.
Okay, thank you. Okay, greetings, colleagues. It's my distinct pleasure to participate in the APSC webinar with you. My topic is hypertension management in acute stroke, and this is my conflict of interest disclosure. And the content of today's presentation can be referred to the 2022 TSOC and THS hypertension guideline. And also, furthermore, the Taiwan Stroke Society's 2020 blood pressure control guidelines at acute stage of ischemic stroke. In addition to introducing the guideline suggestions, we will also review the evidence on which they are based, and we focus primarily on the acute stage management. And first, it cannot be emphasized more about the influence of hypertension on stroke. In a study with around 80,000 participants who were free of stroke, myocardial infarction, and cancer in 2010 or earlier, it was discovered that those with higher blood pressure have a dose-response increased risk of ischemic stroke. Notably, high blood pressure poses an even greater risk for ICH, also in dose-response manner. So let us begin with the BP management for ICH at the acute stage. Here are some general recommendations. And we can take a look at previous guidelines such as 2015 HA/SA guidelines and 2015 TSOC/TSH guidelines for the management of spontaneous ICH. In general, it was stated that SBP should be targeted at 140 mmHg in the acute stage. And the evidence in support of the intensive blood pressure lowering for ICH patients is listed here. The intensive BP reductions in acute stage was associated with a lower hematoma volume and improved functional outcomes in the INTERACT-2, ATTACH, and ICH ADAPT studies. And for example, in the INTERACT-2 study, as demonstrated in this figure, a large SBP reduction in acute stage was associated with a decreased risk of mortality and major disability or the deterioration of the physical function or mortality. Moreover, a large BP reduction was associated with a smaller hematoma growth. And the lower hematoma growth was associated with the faster BP reduction. And we can define that as time to target SBP less than 140 mmHg and more frequent target BP achieved. And in a Japanese study, achieving the target BP faster result in a lower instance of hematoma growth of more than 6 cc. So as a result, here are some brief summary. Our TSOC and THS hypertension guideline recommended that the SBP should be reduced within 1 hour and maintained at the target of at least 140 mmHg for at least 1 to 24 hours after acute ICH. So let us turn our attention to a more complicated issue, the blood pressure management in acute ischemic stroke. And we know that high blood pressure is common during acute ischemic stroke. According to observational studies, around 70% of ischemic stroke patients arrive at the hospital with a SBP more than 140, and 15 of them have systolic blood pressure more than 185. Is it a stress response or a protective mechanism? And to be noted that our brain has a homeostasis mechanism called cerebral autoregulation, which states that the cerebral blood flow remains constant during the normal blood pressure change. But with extreme high or extreme low blood pressure, the cerebral blood flow will increase or decrease. So cerebral autoregulation tightly controls blood flow to the brain by coupling cerebral metabolic demands to cerebral perfusion. In the setting of acute brain injury, such as ischemic stroke, the continual precise control of the cerebral blood flow is vital to prevent further injury. And the chronic as well as acute elevation of blood pressure are frequently associated with stroke. Therefore, understanding the physiology response of the brain to the treatment of hypertension is of critical importance. And the physiology data obtained in patients with acute ischemic stroke suggests that there are no clear evidence that point out that there are no alterations in the intrinsic autoregulatory capacity of cerebral blood vessel, except for the infarct tissue, what we call penumbra. More importantly, the increased blood pressure may be protective mechanism to increase blood flow, while the decreased perfusion pressure may increase infarct size. Therefore, in the acute stage, if we reduce the blood pressure, probably there will be a hypoperfusion cause infection expansion. And the focus update published in Stroke last year also emphasized that there was no simple answer for acute blood pressure management in acute ischemic stroke, given that a number of large trials of BP lowering failed to change outcomes. So how do we best manage high blood pressure in acute stage? Let us examine the evidence. To begin, let us check the data in the pre-hospital stage. And the RIDE-2 study published in Lancet 2019, which used the transdermal NTG on the ambulance. And this randomized controlled trial failed to show any beneficial effect on the short-term and the mid-term outcomes in the randomized controlled trial of RIDE-2 study. And how about the evidence informed decisions for subjects who did not receive thrombectomy, such as intravenous thrombolysis or endovascular thrombectomy? There was no evidence supporting the aggressive BP lowering in acute ischemic stroke within 2 to 3 days of stroke onset in randomized controlled trials such as COSAC, SCST, CATIS, INOS, and CHES. And even aggressive BP lowering in the acute stage can be associated with worse outcome. And similarly, in the MAPA study, 280 patients were randomized within 12 hours of acute ischemic stroke to maintain SBP during 24 hours within 3 range. Group 1, 140 to 160. Group 2, 160 to 180. Group 3, 180 to 200. As you can see, there's similar outcomes among the 3 groups. And after logistic regression analysis, the odds ratio of having good outcome was greater in group 2, 160 to 180. And spontaneous ICH were more frequently encountered in group 3. And the meta-analysis published in Stroke in 2015 on this issue showing that aggressive blood pressure lowering in early ischemic stroke had a neutral effect on the prevention of death or dependency. As a result, we recommended that there's no evidence to support routine aggressive BP lowering unless the patient had extremely high blood pressure, more than 220 and 120 millimeter mercury within 24 hours of acute ischemic stroke. However, the recommendation may differ if thrombectomy is attempted using either IVT or ICT. And the recommendations before intravenous thrombolysis is based on the Kadro trial exclusion criteria and some data from the protocol violation, which shows that the hypertension prior to IVT was associated with increased risk of ICH. As a result, the pre-IVT blood pressure should be less than 185 and 110 millimeter mercury. So how about the blood pressure after successful recanalization? The study by Goya et al. Suggests that BP between 140 to 100 and 160 over 90 millimeter mercury versus permissive hypertension was associated with a lower mortality rate. So the blood pressure should not be too high after successful recanalizations. In a large registry of more than 11,000 subjects, a higher blood pressure of subjects receiving intravenous thrombolysis was associated with ICH and poor outcome. Therefore, the blood pressure should be within the range between 140 to 160 from this registry. And lower blood pressure after IVT randomized control trial in Enchanted study, and which targeting at blood pressure at 130 to 140 did not improve all the outcomes of acute ischemic stroke patients less than 60 hours after IVT. As a result, in acute ischemic stroke undergoing IVT, a blood pressure greater than 180 and 105 is associated with increased risk of ICH and poor clinical outcome. And lowering blood pressure less than to a range around 140 to 150 or 160 may be possible to reduce the further future risk of ICH, but it will not result in improved functional outcomes. So let us move on to the subjects undergoing endovascular thrombectomy, EVT. So similarly, the blood pressure recommendations before endovascular thrombectomy is based on the RCT exclusion criteria. In recent years, 5 of the 6 major EVT clinical trials, such as REVERSE, SWIFT, EXTEND, THRACE, MR, CLEAN, DOWN, they all adopted the exclusion criteria of 185 and 110. And the study suggests that the blood pressure greater than 185 and 110 is not recommended. But until more clear evidence supports other blood pressure target, the blood pressure control should be comparable to those for IVT, and it is a reasonable approach to adopt the similar the target labels for both IVT and EVT. So how about the blood pressure during the EVT? There are some observational studies conducted to demonstrate the effect of BP reductions and the functional outcomes. As you can see, all these observational studies showing that the aggressive BP reductions in terms of mean BP was associated with poor neurologic outcome following EVT. And here are some systematic review. And this review published in Stroke in 2019 suggests that the EVT under general anesthesia showing that the effects of the blood pressure reduction caused by anesthesia are associated with a poor prognosis. As a result, many observational studies have begun to investigate the blood pressure control in EVT in recent years. And this systematic review suggests that the blood pressure can not be too low or too high. So we recommend that for patients undergoing EVT, it is reasonable to avoid the decrease in mean arterial blood pressure by over 40%. And for patients undergoing EVT, if the mean BP cannot be obtained, we can use SBP between 140 and 180 mmHg as a guide. And the Society of Neuroscience, Neurointerventions Surgery, and Neurocritical Care Society issued a joint consensus statement on anesthesia for intraarterial management of acute ischemic stroke in 2014. The guideline recommends that the blood pressure be monitored every 3 minutes during surgery, and that the systolic blood pressure should be kept between 140 and 180 mmHg, and the diastolic blood pressure kept below 105 mmHg. In contrast to IVT, which cannot be directly defined the successful recognition of blood vessels, the EVT surgeons can use angiogram to see the blood vessels are opened or not after surgery, and how well they are supplying to the brain. And if the surgery is successful and the blood vessels are recanalized, but the blood pressure is too high, bleeding may occur. But if the vessels stay blocked after the procedure, the low blood pressure is likely to cause the bad things to happen. And this study, which published in Neurology, showing that the maximal SBP and the DBP of people who have been independent for 3 months were lower. And subjects who died in the first 3 months had a higher maximal SBP and DBP. So blood pressure should not be too high after the EVT. And it shows that the per 10 mmHg increase of the maximal SBP and DBP was associated with a lower odds of the functional independence and higher odds of mortality. And in the retrospective study, subjects with better functional outcomes and better cerebral perfusions and had a lower SBP and lower DBP compared to the worst group. And a previous multi-center retrograde analysis looked at around 10,000 cases of patients receiving EVT and successful recognitions. And all patients were divided into 3 groups based on their 24 hours post-operative SBP, 140, 160, and 180. And as you can see, and the subjects with less than 140 was associated with a better functional outcomes, modified ranking score, and controlling SBP to less than 160 was associated with a lower 90-day mortality. Therefore, the blood pressure after successful randomization should not be too high. And there was an IPD meta-analysis included around 58,000 subjects with acute ischemic stroke during the after the acute ischemic stroke because of the large vessel occlusion. And this paper published in Neurology 2022 suggested that every 10 millimeter mercury increase in the first 24 hours after EBT was associated with 20% of the increase in ICH, 14% increase in early neurologic deterioration, 15% increase in 3 months all-cause mortality, and 13% increase in the favorable functional outcomes. And more importantly, whether recognition or not, they did not modify the treatment effects. And in another BP trajectory study after IVT was published in Stroke in 2022, and they divided subjects into 5 groups: low, moderate, moderate to high, or high to moderate or high. And as you can see in this figure, with the blood pressure in high group, the functional outcomes is worse. The TICI, the cerebral perfusion, is worse. So subjects in the high BP group had a larger proportion of poor cerebral perfusion, and also a higher odds of unfavorable 90-day functional outcomes, unfavorable the risk of ICH. And after these observational studies, we recognize that randomized controlled trial are needed. And in a study published in Taiwan, lower mean, maximum, and SD value and of systolic and diastolic blood pressure observed in the first 6 hours after EVT were independently associated with functional independence. And furthermore, the area under curve was the highest for the first 6 hours blood pressure following EVT. And there are some randomized controlled trials currently being conducted to help answer the questions. And of them, BP target has just been published, in which the acute ischemic stroke patients after successful EVT were randomized into 2 groups with SBP targeted at 100 and between 100 and 130, and 130 to 185. And as you can see, an intensive blood pressure reduction after successful EVT did not reduce the radiographic ICH at 24 to 36 hours when compared to the standard blood pressure control between 130 and 185. And notably, these findings apply to patients with successful reperfusion and with a systolic blood pressure greater than 130. And another studies recently published in Enchanted-2 studies, and this study compared SBP target at 120 versus 140 and 80 in acute ischemic stroke patients after EVT. And the result shows that the intensive control SBP to less than 120 should be avoided because it can jeopardize the functional recovery in patients who had undergone EVT. And showing in figure 3, you can see that the good functional outcome is more common in subjects with less intensive treatment group. And for secondary outcome, more intensive treatments had increased odds for neurologic impairment, major disability, or death. Therefore, we recommended that for patients receiving endovascular thrombectomy, it is reasonable to maintain the blood pressure to less than 180 and 105 within 24 hours after the procedure. If successful reperfusion is achieved, maintaining BP at lower values such as less than 140 and 90 within 24 hours after the procedure can be considered. But intensive control SBP to lower than 120 should be avoided to prevent compromising the functional recovery of patients who receive EVT. So my presentation is coming to an end. I would like to leave you with some takeaway. This slide summarizes the acute BP management strategies for acute ischemic stroke. Before undergoing IVT or EVT, the blood pressure should be kept below 185 and 100 millimeter mercury. And the BP should not be more than 180 and 105 after the IVT. But for the patients during the procedural EVT, the SBP should be kept between 140 and 180. But too aggressive BP reductions should be avoided. And within 24 hours after EVT, for the patients with failed recanalization, the blood pressure should be kept below 180 and 105. But for subjects with successful recanalization, the blood pressure should be less than 140 and 90. But the blood pressure should not be less than 120 to avoid the further functional deterioration. Thanks for your attention. It's my presentation. Is there any questions from the audience? Dr. Moncy, can you open your mic?
Oh, sorry. Sorry, my mic was mute. So thank you very much, Dr. Cheng, for your excellent talk. So I think we are short of time. We need to go to the next speaker. Okay. Or I think it is already time.
Okay.
So we'll go to the next speaker.
Okay, let's welcome Dr. Natarajan.
Yeah.
Dr. Natarajan is a professor and head of the EP divisions and the Emerita Institute of Medical Science in India. So his topic will be the hypertension management in the elderly and very elderly, the implications of high-beat, sprint, and step trials. Let's welcome Dr. Natarajan.
Thank you. Can you hear me?
Yes.
Okay. Let me share my screen. Are you able to see my screen?
Yes, yes, we can.
Thank you. So at the outset, I thank the Asia Pacific Society of Cardiology for inviting me to be part of this webinar, the Asia Pacific Hypertension Summit. And I also thank Professor Vijay Ban, the President of the Cardiology Society of India, for having nominated me as a representative from the Cardiological Society of India. So in the next 15 to 20 minutes, let us talk about hypertension management with reference to the elderly, that is more than 65 years, and the very elderly, more than 80 years, and the implications of these three relatively recent trials, the HIVET, the SPRINT, and the STEP trials. So that is the map of India in the global map. That is India. I belong to a state called Kerala in the very south of India. And this is my institution, Amrita Institute of Medical Sciences, Cochin, in Kerala in South India. So we'll go through the following points. What are the risk factors and the pathogenesis of hypertension with particular reference to the elderly? The contribution of hypertension to cardiovascular and stroke risk. What are the problems specific to hypertension in the elderly population? What is the impact of antihypertensive treatment in the elderly patients? What were the earlier concerns? The earlier concerns were that if you aggressively treat hypertension in the elderly, the stroke risk may come down, but there is an increase in the overall mortality. So the benefits in terms of stroke reduction is blunted by the overall mortality, which was a significant concern many years ago. So people were worried to treat patients with hypertension, particularly in the very elderly population. What are the benefits of stroke prevention with control of BP in the elderly? Newer randomized trial data confirming the benefits of BP control in the elderly population, that is the HIVET, the SPRINT and the STEP trials, which is the very purpose of this particular session. And what are the guidelines and recommendations? So we'll address these points one by one in the next 15 minutes. What about the prevalence and pathogenesis of hypertension in the elderly? As age advances, there is a proportionate increase in the incidence of hypertension, as low as 8% in 20 to 34, as high as 75%, both affecting men and women above the age of 75. There is an increase in the incidence of hypertension with age. Pathogenesis of hypertension in the elderly, age itself is a very high risk factor. Age increases arterial stiffness, which in turn increases systolic blood pressure, which causes left ventricular hypertrophy, diastolic and systolic heart failure. Increasing the systolic pressure contributes to atherosclerosis, with coronary artery disease, cerebrovascular disease, aortic aneurysm, dissection, so on and so forth, and also increases the incidence of chronic kidney disease and renal insufficiency. So these are some of the pathogenetic mechanisms of systolic hypertension in the elderly and the clinical consequences. The central aortic pressure as age advances increases. If you look at the central aortic pressure as in the age group 24, it is much lesser as opposed to age 68, where the central aortic pressure increases. So the central aortic pressure increases as a factor with advancing age. And if you look at the incidence of systolic versus diastolic versus mixed hypertension, as in the age less than 40, there is significant incidence of isolated diastolic hypertension, combined systolic and diastolic, and isolated systolic hypertension is very less in frequency at an age less than 40. If you look at it at the age above 80, predominant hypertension is isolated systolic hypertension, and combined systolic and diastolic hypertension is much lesser. So isolated systolic hypertension is a problem one has to consider when we deal with elderly age group of patients. The contribution of hypertension to cardiovascular and stroke risk in the elderly is something that to be very aware of. This shows that the Asia Pacific cohort studies collaboration, the prospective studies collaboration, all tell you that as systolic blood pressure increases, so is the hazard ratio of stroke. So the stroke risk increases as the systolic hypertension increases in magnitude. So increased incidence of hypertension more than 65 years contributes to stroke risk, atrial fibrillation, heart failure, chronic kidney disease, and dementia. And moreover, hypertension in the elderly is associated with an accelerated decline in the overall health status and also contributes to frailty in the elderly population. The classification of hypertension, the age plays a vital role when decisions are made regarding treatment and target BP, taking into account factors that are specific to the elderly population. There are no definitions per se to take into account the age of the population. The definitions are still the same, whether you're dealing with a younger population or an earlier population. However, age has a direct bearing on the way we treat hypertension in the elderly population. What are the risks and threats of treating hypertension in the elderly population? Why are we so concerned about treating hypertension in the elderly? Because there are some perceived risks and threats of treating hypertension in the elderly. Particularly, orthostatic hypotension is a potential problem in the elderly population. Orthostatic hypotension affects the prognosis of older patients by increasing the risk of syncope, falls, and this can in turn increase the cardiovascular risk and all-cause mortality. When treating hypertension in the elderly, antihypertensive therapy should be carefully titrated, taking into account the BP in the standing position, which should be part of the standard evaluation of patients in the older age group, more so when they are very frail as well. So orthostatic hypotension is a very important problem in treating hypertension, specifically in the elderly population. And in particular, autonomic dysfunction, which happens in diseases like Parkinsonism, diabetes, and frailty, should be carefully considered in order to avoid orthostatic hypotension. And concomitant diseases like aortic valve stenosis, heart failure, atrial fibrillation, reduced renal function, endocrine diseases like thyroid disease, and associated polypill therapy also contributes to orthostatic hypotension when treating patients in the elderly population. All of us are quite aware of the concerns regarding the J-curve for benefits versus harms of antihypertensive therapy. As the systolic BP, as the diastolic blood pressure comes down, you have a lot of benefits in terms of survival. But if you bring the diastolic pressure to very low levels, there is an increase in the mortality. This is true also of systolic blood pressure. As the systolic blood pressure comes down from 180 to 140, there is improvement in survival. But as the systolic blood pressure drops below 140, there is an increase in the mortality. So this J curve is particularly relevant when you deal with elderly patients with hypertension. Orthostatic hypotension is a problem of elderly patients, and comorbidities and frailty contribute to functional decline. And this study clearly shows that orthostatic hypotension is a major problem which contributes to acceleration of dementia in the elderly population. What is the impact of treatment of hypertension in the elderly? The stroke risk versus the mortality risk, the paradox. As the stroke risk comes down with treatment of hypertension in the elderly, there is a paradoxical increase in the mortality as shown in previous studies. If you look at the Indana group study, which was published in the Lancet in 1999, if you look at the treatment benefits of stroke, the stroke significantly comes down with treatment of hypertension. So antihypertensive treatment reduces the risk of stroke. But if you turn the tables and look at the mortality risk with hypertension, the mortality is not better. With hypertension, the mortality is not better. So though the stroke risk comes down, the mortality risk does not. In fact, it paradoxically goes up, as was shown in the Indana group, which is a very old trial, about 25 years old study. If you look at the more recent, we are going to talk subsequently about the HIVET trial, which is hypertension in the very elderly population. If you look at the pilot study of the HIVET study, this was published in 2013. If you look at the conclusions of this pilot study, the preliminary results support the need for continuing the main HIVET trial. It is possible that the treatment of 1,000 patients for 1 year may reduce stroke events by 19, of which 9 is non-fatal, but may be associated with 20 extra non-stroke deaths. This is a very important information which was made out in the pilot study. You may reduce the incidence of stroke, but you have to be careful about the increase in the mortality risk with antihypertensive treatment, was the in conclusion of the HIVET pilot study. And if you look at the comparison of all these trials at this particular stage, the stroke events definitely comes down with treatment. However, the total mortality and the cardiovascular mortality was higher with treatment. So we have a paradox of reduction in stroke, but an increase in the mortality when you treat hypertension in the elderly population way back in these studies, which were published in 1999 and 2003. So antihypertensive therapy in the elderly may reduce the risk of stroke, but with the possibility of increasing the risk of death. Whether treatment of hypertension in the elderly population is beneficial was unclear at this time. So now let us answer the final question. Is the treatment of hypertension in the elderly patients truly beneficial in today's time? We have few landmark studies on the treatment of hypertension in the elderly population, which is the primary focus of this particular talk. The HIVET study, which is treatment of hypertension in patients more than 80 years of age, versus placebo, which was published in New England Journal in 2008. Then the SPRINT research group, which is a comparison of intensive versus standard blood control, which significantly recruited elderly population, which was published in 2015, again in the NEJM. And the more recent, the STEP study group, which is a Chinese study, a trial of intensive versus a standard BP control in older patients with hypertension, which was published a couple of years ago. So let us look at these trials a little more carefully. The HIVET study, published in 2018, involved patients more than 80 years of age, mean age of 83.6, 3,845 patients, involving Europe, China, Australasia, and Tunisia, the mean follow-up of 1.8 years. The standard release diuretic indapamide 1.5 milligram or placebo was the initial treatment. And if the blood pressure is still not controlled, ACE inhibitor perindopril, either 2 milligram or 4 milligram, was subsequently added. Mind you, this is a placebo-controlled trial. So this drug versus placebo. And what was the target blood pressure? 150 by 80. The primary endpoint was fatal or non-fatal stroke. If you look at the systolic blood pressure, this is in the placebo group. This is the active treatment group. There is a significant fall in the systolic blood pressure as well as in the diastolic blood pressure in this particular trial with a combination of indapamide plus minus perindopril. And what was the outcomes? If you look at fatal or non-fatal stroke, there was a significant benefit in the active treatment group. Death from any cause, again, significant benefit. Death from cardiovascular causes, again, there is a lot of benefit from the active treatment group. And death from stroke, that again was significant. Death from stroke was not significant, but then death from stroke also was significant with a hazard relative risk of about 39%. So 30% reduction in non-fatal or fatal stroke, 21% relative risk reduction from all-cause mortality, and death from stroke was less by a relative risk reduction of 39%. All these were significant benefits. So we understand from this HIVET trial that even in the elderly population, targeting a blood pressure of 150 by 80 with antihypertensive treatment is quite beneficial. And heart failure also was significantly lesser, 64% relative risk reduction of heart failure. Moving on to the SPRINT study, which was published in 2015. This is a randomized controlled trial of intensive versus standard BP control in patients with systolic BP of 130 plus high cardiovascular risk, but without diabetes. This was in patients more than 50 years of age. 9,000 odd patients were recruited. The mean age was 67. So it addresses the question that whether BP control is useful in elderly population. 28% of the patients were more than 75 years of age. In the intensive arm, the systolic BP target was less than 120. And in the standard treatment arm, the systolic BP target was less than 140. And the primary composite endpoint was MI, other acute coronary syndrome, stroke, heart failure, death from cardiovascular causes. The trial was prematurely stopped after a median follow-up of 3.26 years because of a significantly lower rate of primary composite outcome in the intensive treatment arm. The intensive treatment arm was significantly beneficial as compared to the standard treatment arm. So the trial was stopped after 3 years. If you can look at the mean systolic BP in the standard treatment arm, 136 versus 121.4 in the intensive treatment arm. If you look at the primary outcome, the intensive treatment arm was significantly beneficial, 25% relative risk reduction. Death from all cause, 27% relative risk reduction, both were statistically significant. So we understood that intensive treatment from the HIVET trial, we understood that 150 by 80 itself is beneficial. If you further reduce the blood pressure to more intensive levels, you have significant difference in both primary outcome as well as all-cause mortality. And both age less than 75 as well as more than 75, intensive treatment was superior in the subset analysis. And if you look at the adverse effects as expected, hypotension, syncope, acute kidney injury, all that was higher in the intensive treatment group as we expect. Serum sodium lesser, serum potassium being lesser, all that was lower. But it's interesting to know that adverse events as defined by fatal or life-threatening complications was not substantially different between the two arms. Hypotension is a problem that you should keep in mind when you intensively treat elderly population, but it's not quite serious enough to cause death or debility. The last trial, that is STEP study published in 2021, which is a Chinese study, again intensive versus standard BP control in patients with hypertension and high CV risk. In patients aged 60 to 80 years, 76% of the population was 60 to 69 years, and a quarter of the patients was more than 70 years of age. Again, the intensive arm, the systolic BP target was 130 to 129, And in the standard arm, it was 130 to 149. So this is again intensive versus standard therapy. The mean follow-up of 3.3 years. And this was the primary endpoint, almost similar to the SPRINT trial itself. Again, there is a significant reduction in the mean systolic blood pressure and the mean diastolic blood pressure in the intensive treatment arm as compared to the standard arm. If you look at the cumulative incidence of the primary composite endpoint in the intensive treatment arm, it was 26% reduction, relative risk reduction. So a lot of benefit with intensive treatment, even in this large trial. Safety outcomes were no different. Only hypotension was statistically significant. Otherwise, all other parameters. So in this trial, it was found that it is quite safe to treat patients with elderly population with intensive treatment as well, without the fear of complications. So there is even more recent reassuring data on antihypertensive treatment in elderly frail patients, which was a major concern in the past. If you look at this particular publication in 2020, antihypertensive treatment in the elderly frail patients from a large Italian database. As the clinical status deteriorates, the survival probability drastically comes down. But it is interesting to know that if you adhere to antihypertensive treatment, whether it is a very low risk or low risk, if the adherence to therapy, even if they are very frail, was a very encouraging data from this large Italian database. And this trial, which is a more recent trial, clearly showed that antihypertensive treatments do not have that much of a significant deleterious effect on cerebral blood flow, which is again a very encouraging data. Current evidence does not suggest a harmful effect of antihypertensive therapy on cerebral blood flow. So what about the guidelines? All guidelines clearly say that the targets can be as low as 120 to 130, even in the elderly population, whether it is AHA, whether it is ESC. If you look at the ESC data, the treatment target, the treatment threshold is 160 systolic and more than 90 diastolic target, even in patients more than 80. So the current ESC guidelines suggest specific recommendations for very old or frail patients to maintain BP a little higher, 130 to 140 millimeters systolic and 80 to 90 diastolic target if tolerated, and to consider monotherapy as a first-line strategy in these patients because of the issues of orthostatic hypotension. So from the data 20 years back, we now know that it is safe to treat patients in the elderly population with antihypertensive treatment. And if the patient is very elderly and very frail, you don't have to be very aggressive according to the current guidelines. So I'll conclude by saying that the prevalence of hypertension increases with increasing age. Hypertension contributes to enhanced cardiovascular and stroke risk in the elderly population. For many years in the past, advanced age has been a barrier to the treatment of hypertension because of the concerns about potential poor tolerability, like orthostatic hypotension, and even harmful effects of BP lowering interventions. This approach is not appropriate because newer evidence from the randomized control trials that we discussed in detail, the Harvard study of 2008, the SPRINT in 2015, and the STEP study in 2021, has clearly shown that in old and very old patients, antihypertensive treatment substantially reduces cardiovascular morbidity, as well as all-cause and cardiovascular mortality as well. Thank you for your kind attention.
Thank you. Can I have a questions for Dr. Natarajan?
Sure,
This year in June, ESH has issued an updated guideline, and this version of guideline is similar to last version, and we suggest that for the very elderly, more than 80 years old, that the blood pressure should be considered to treat unless 160. So what's your opinion on this? Is it too high a threshold? Will you leave the patients more than 80 years old and SBP more than probably 150, that not treated?
The threshold for therapy was 160 in the 2018 guidelines, as you correctly mentioned. And there is not much of a change in the updated guidelines, which was published by the European Society of Hypertension recently. That is for the fear. But I personally feel that going by all this data, the threshold can be brought down and the target should not be very low, as you correctly said. Maybe we can settle for 130 systolic rather than less than 120 that you will aim for in a relatively younger group. But as you correctly mentioned, you don't have to wait for the BP to go above 160, but that's what the guidelines suggest.
Dr. Natarajan, I have one question. So
Sure.
in your day-to-day practice, what do you follow for an elderly person above 80 years? You follow as a 130/80 or a bit higher as a target for controlling blood pressure on patients on antihypertensive drugs?
I will accept a BP of 140 systolic and 80 diastolic. But the only problem which we commonly come across in the very elderly population is the fact that you deal more with isolated systolic hypertension. I have many patients under my personal follow-up who have BP of, let's say, 170/70. They have wide pulse pressure because of thickened arteries. And the minute you start bringing down their systolic blood pressure, which is very difficult, you may need multiple drugs to bring down the systolic blood pressure to meaningful levels like 140. And there is always a small concern about the diastolic BP dropping down to 70, 65 like that. I have some of my patients where with multiple drugs, the systolic BP comes to 140, but the diastolic also comes to 65. And this can contribute to reduction in coronary blood flow, which can have a paradoxical effect on the cardiac death. So that is you have to walk a tightrope when you deal with isolated systolic hypertension, which is quite a common problem. And it's quite difficult to treat, as you will agree with me.
I think we need to take into account of the diastolic pulse pressure in treating hypertension, particularly in the elderly people, when we encounter about this isolated systolic hypertension.
Correct.
Dr. Cheng, if no more questions, shall I conclude?
Yes, please move on. Thank you.
Okay. It is actually has been an extremely rewarding and enlightening endeavor of the APSC, bringing together all of us with the interest in the hypertension, in the extremes of age, stroke, and pregnancy, high altitude, or extremes of weather. I think we had a very comprehensive discussion and a talk, which is, I think, quite useful. In conclusion, I would like to thank everyone who has been involved in this webinar and hope it will be very useful for the practitioners who are taking care of patients with hypertension. Thank you all. Thank you very much.
Thank you.
Thank you.
Thank
Thank
you.
you all.
Very much.
Thank you. Bye-bye.
Bye-bye.
Thank you all.
Thank you.
Thank
Waleed.
you.
Thank you.
Yeah. Thank you.
Thank you. Bye.
Bye-bye.
Bye.
Bye-bye.